Okay, Jessica, should we get started?
Yeah, go ahead.
Okay, awesome. Welcome, everyone. It is my great honor to introduce Dr. Flora Nwagagbo. She is a medical doctor and public health professional, and we are lucky to have her as a current lead fellow here at Harvard this year. So she is the senior program specialist in TB, HIV care and support, leads the TB HIV implementation of the PEPFAR program for the CDC in Nigeria. She also serves as the incident commander for the HIV treatment program, focused on scaling up access to antiretroviral treatment in Nigeria and achieving HIV epidemic control. On top of all that, she oversees the financial, technical, and programmatic management of multi-component awards for CDC Nigeria. And prior to joining the CDC, she strategically led the implementation of large-scale, high-impact health projects funded by multinational companies, the USAID and the Global Fund, in the public and private sectors of Nigeria. She is going to talk today about leveraging improvement science for program implementation. And we are so lucky to have her here as a lead fellow this year. We'll ask you to, while she's talking, either just put questions in the chat or to raise your hand and interrupt with clarifying questions, and otherwise to wait till the end to ask more than clarifying questions. Flora, we're delighted to have you take it away.
Okay, so good afternoon, everyone. Let me start by thanking all of you here today, both in person and virtually. I also want to thank the Department of Global Health and Population and the Harvard Global Health Institute, both at the Harvard T. Chan School of Public Health, for this opportunity to share our experiences with you. The young woman you see here on the screen is, well, she's well known to me. Her name is Flora. She's been implementing programs across Nigeria, including the creeks of the Niger Delta, which is where she is, in the picture you see there. And together, we will be sharing with you what we've learned in the course of our work. So this is our outline for the discussion we're going to have today. I understand that we have many experienced researchers and budding researchers here. But I want to invite you all to take off your researcher lenses, right? And put on these implementers lenses. So I call them the lenses of the change agent. They're not fancy, but please bear with us, okay? Now, when we implement programs, most times our aim is to improve the state of the system, right? Maybe move it from one state to another, usually to a better state. But what informs the interventions that we implement? Usually it's evidence, and this evidence is got through research. But have you ever wondered why it is that even when you have strong evidence that an intervention works, you push it out there, but after implementation, you conduct maybe an evaluation or a full-blown study, and then you find that it didn't quite give you the impact that you hoped for, or perhaps even predicted? Well, I have found that a leadership mindset is critical to making change happen. A leadership mindset to me is the ability to, take charge and work with people to get things done. Leadership really is an art that we can actually leverage it to turn science into action, such that you see the changes that your research predicted. Now, imagine yourself as a newly employed healthcare provider, or say an attending in a hospital, and your first posting is to the emergency department. The commonest causes of death in the emergency department are respiratory diseases, heart diseases, and trauma in this order. But here you are in the emergency department, and then you observe that patients with respiratory diseases are given minimal attention, they're glossed over, or they're referred to another hospital, right? You also observe that because they are not thoroughly reviewed, many respiratory conditions are not diagnosed or are misdiagnosed. Then say on further observation, you find that it's an extremely busy department, right? They've got the staff there have got their hands full. Most of the doctors are cardiac and trauma specialists. And really, this is another reason why they focus more attention on cardiac and trauma cases. Well, this is how I felt in December of 2020 when I joined the US President's Emergency Plan for AIDS Relief PEPFAR program of the US Centers for Disease Control. I was asked to lead the TB component of the program. But you know, when you want a shoe, you will know where it pinches. So I could relate to the struggles I met. I had implemented programs for many years, and sometimes it just makes sense, you know, to focus on your target population, you know, just maintain that laser focus on your primary assignment, you know, and ensure you deliver on it. And trust me, HIV programming is massive. I mean, I think I got my hunch back from my many years in the HIV program, and my gray hair, maybe from coming back to it, you know, in recent times. But for the PEPFAR program, our overall goal really is to prevent HIV infections and accelerate progress towards achieving HIV/AIDS control. The Nigeria PEPFAR program has made great progress. In a country, think about it, in a country of over 200 million people with an HIV prevalence of 1.4%, which actually is down from about 5.5%, which is what it was in 2002. And currently we have over 1.8 million people living with HIV who are currently on HIV treatment. I believe we've come a long way. Now, tuberculosis, which is commonly called TB, is a respiratory disease, and it is spread through the air. You know, when an infected person coughs, sneezes, talks, or sings. Now, it is a leading cause of death worldwide. And before COVID-19, it was really the leading cause of death from an infectious disease globally. But following the swift and dramatic progress to rein in the COVID-19 pandemic, TB is back to being the dreaded number one. Now, among people living with HIV worldwide, TB is the leading cause of death. Let me repeat that. Among people living with HIV worldwide, TB is the leading cause of death. About 28 to 30% of all the deaths among people living with HIV are due to TB. And these deaths, quite frankly, are preventable. People living with HIV have about 19 times the tendency to develop TB, you know, compared to somebody who doesn't have HIV. Now, when we come to Nigeria, Nigeria has the 6th largest TB burden in the world and the highest TB burden in Africa. And my country, that's Nigeria, ranks 3rd among the countries of the world with the highest number of people who are co-infected or dually infected with TB and HIV. Now, our TB/HIV activities in the PEPFAR program, they're geared towards reducing TB-related morbidity, which is illness, and mortality, which is deaths among people living with HIV. Remember, people living with HIV are really our core target population for the PEPFAR program. Studies have shown that systematic screening of everyone can help to identify people with signs and symptoms of TB. Now, people living with HIV are one of the high-risk groups that will benefit from TB screening because, I mean, they have lower immune response due to immune suppression, which tends to predispose them to developing TB disease or progressing rapidly from TB infection to TB disease. And, you know, bearing in mind that Nigeria is a TB endemic country, the number of people with TB infection is quite high. So to this end, the World Health Organization, that's WHO, recommends that people living with HIV should be routinely screened for symptoms of TB. And when TB is detected, they should be linked to diagnostic facilities for, and then offer treatment or prevention, you know, depending on which one is appropriate. Now, just to explain to you how we do our TB in Nigeria, in Nigeria, when we talk of TB screening, we actually use primarily the WHO 4-symptom screening. So it's not like in the US where you use chest X-ray, routinely. For us, we use these 4-symptom screens where we ask people about 4 key symptoms of TB: cough, fever, weight loss, night sweats. In people living with HIV, we would ask for, instead of asking for cough of maybe 2 weeks or more, we would ask for cough of any duration. In children, we tend to ask a whole lot more questions. So, we also screen for people living with HIV and really the general population with chest X-ray, but not a lot, because we don't have ready access to chest X-ray facilities in Nigeria, due to cost and then the location of a few available chest X-ray machines in the country. However, we are making efforts to improve access to chest X-ray, and hope that this will help us to improve the diagnosis of TB. Now, back to my story. Here I am in December 2020, newly engaged to lead the TB program in CDC Nigeria, a one-woman riot squad, by the way, although I didn't quite envisage a riot when I assumed the role. Now, I was presented with this picture at every technical meeting in country and even outside Nigeria. It was worrisome that only 88% of the people living with HIV in our program were screened for TB. So this meant that about 12% of people living with HIV were not screened. Now, I know this number appears small, but when you remember that one untreated person with TB will likely infect 12 to 15 others in a year, then you would see why this was a pain point for us as a program. The longer someone with TB, particularly someone with pulmonary TB, remains undiagnosed and untreated, then the more the risk of TB transmission to others. And Nigeria is a country that has high population and great overcrowding. So these will definitely increase the risk of transmission, right? To make transmission very easy. And that's why we also realize and recognize that there is a need to also address some of these important determinants of disease transmission. But that's a discussion for another day. Okay. So while thinking through what I was going to share with the Harvard community, I shared my thoughts with another lead fellow, Cholwe. And she said to me, Flora, you should come up with a framework to explain your lessons learned. So this schema you see here is the framework I came up with after my discussion with her. Besides barriers to implementation, such as the applicability of the proposed interventions to the locality or other systemic and structural barriers, another reason some of our well-researched and evidence-based interventions and strategies don't translate to significant change in the system is really because they are not adequately or appropriately catalyzed. I think this is what we have seen. So the evidence is the science informed by research. Improvement science is also a science with tools and techniques to help us make positive change. But to move from science to action or change, it requires the application of human creative skills and imagination, also known as arts. So it is important to know how to apply this science so that it makes a positive difference in the lives of people. So I dare say that it requires a leadership mindset and the art of leadership, which is caring about the work to be done and caring about the people. This leadership mindset, if you ask me, should start from our research, which should be equitable. It should desire the good of people, the good of others. So it should focus more on what is in it for them and not focus on personal interests. What's in it for me? In our research, we should desire to improve lives and reduce disparities, not just extract data, to add to the body of knowledge or churn out publications. So the leadership mindset is what drives us to learn about the science, the tools and techniques of improvement science, and then how to apply them in such a way that we can create real sustainable improvements. Not just in the lives of the people, by the way, who will receive the intervention, but also in the lives of the people who deliver the services. So that way they know that what they feel and know and are confident that what they're doing is making a lot of difference. So I had two options regarding the pain point of our TB, of the TB component of our program. One was to maintain the status quo, regardless of how many people living with HIV remained undiagnosed and untreated if they had TB. In other words, just lay low and not rock the boat. Or I could do something about it, which means attempt to make a change and be seen as a fly in the ointment. Leadership is responsibility, so I chose the latter. I had to do something about the situation. I had to create change, but the challenge was I was a one-woman riot squad. Now, this is where a change management approach comes in handy. This is the Kotter's change theory, and it's one of several change models. But I love it because it is simple. It shows us how anyone, regardless of their position in an organization, team, or project, can lead change. It prepares and builds acceptability. It prepares people for change, really. It shows us how to inspire and create a new reality, which we can cascade and then people can run with. So there are other change models, by the way, but this was the template we essentially followed. So I had to create the need for change, but how did I do this? I started by creating a burning platform, using facts, using data, right? I also used emails and then WhatsApp groups where we had our staff, so just bombarding them with information so that they begin to understand the need, the why. I leveraged opportunities provided at work meetings, forums with our partners, you name it. The point was just to make a case for change in the quality of TB screening, which was potentially affecting the overall quality of our program. Now, having others on board to champion, communicate, coordinate, and guide the plan was really important. So I reached out to colleagues and senior leaders. More importantly, though, I set up a team from among our implementing partner organizations. They are the closest to the process owners, the frontline teams, and the staff, so they were required. I mobilized help, and believe me, I got it. Now, it was at this point that I made the transition from me or I to we. Please note this. You know what they say, alone you can go fast, but together you can go far. And keeping this in mind is important. Working with others, we now had more energy, more strength to make a case to the rest of the program on where we could be if we did things differently and what we needed to do to get the required results. The benefits to the clients and the patients were placed at the fore, and we were serious about it. We communicated our vision, the plan, strategies, and subsequent improvements. We opened up several channels of communication within CDC in Nigeria, to CDC in Atlanta, within our implementing partner organizations, and then between partner organizations at all levels from top to bottom. We also opened up communication channels with government, and even their counterparts in the states where we were supporting. And then, of course, in the facilities and the communities where the process owners were. So you can imagine the communication channels we just had to, open up so we could engage everybody. We also engaged our sister PEPFAR agencies. So we have the USAID, United States Agency for International Development, and then Department of Defense. we had to include them because PEPFAR, beyond CDC, there's also USAID implementing the PEPFAR program, and then there's DOD. So even if we achieved 100%, it would make no difference because we had to think of the nation as a whole. We all had to move together. So we did not leave them out in this effort. We pulled them in, worked together, and scaled our improvements throughout the PEPFAR Nigeria program. For our teams, we started building capacity. I'm spending some time here just so that you can understand some of the things we needed to do to be able to get the kind of change we desired. So we built capacity of the teams, we showed up their knowledge of the TB cascade of care, and we showed them how to lead change. You know, many times we assume that people know what to do and how to do them. They may, but they could also learn a better way. In fact, a better and more effective way of doing things. And this is what we set out to do. So we empowered people to be and to do better, you know, and this is what capacity building is really. We also created an environment, particularly among the implementing partners, that fostered, you know, that environment that fostered learning, growth, creativity, and knowledge. Well, more knowledge sharing, you know. We tried to break the silos so that our implementing partners could work together. We were all moving towards a shared vision. And then we also needed them to develop a voice so that they could be able to, you know, set strategic directions in the places where they were working and the teams that they were leading. So they began to understand that they didn't need a big title, or they didn't need a big title to influence change. They just needed to step up. You know, meanwhile, on the side, we would work to remove barriers. In some cases, we saw that the team leads or the leadership of those organizations had deprioritized TB. So what did we do? We engaged them. If they met stone walls with the state program managers or other partners, we intervened. The idea was to make the system of change easy, in quotes, so people could move the plan forward. Now, one of the principles of improvement is that you should start small, and that was what we did. You know, we tested our plan in a few states, made several tweaks, and when we saw the improvements, we scaled up to other states. Now, the greatest work really in an improvement effort is incorporating the change and sustaining the improvements. So they become, so that the idea is to make them become a way of doing things, a culture. We've started that, and I think we're still on it. I believe this is really the second phase of the effort for us. So this is essentially, this slide shows us how we use improvement science. You know, improvement science helps us understand how systems work. It provides us with the tools to identify any breakdown in processes and actions to be taken to improve performance and outcomes. We use these tools, we used a few of this, we use all the tools here actually, and deployed them to help us identify the problem, the root causes and the problems to be addressed, prioritize them so that they gave us the best value, you know, and most impact. We also used what we call the PDSA cycle, which is another QI technique where you plan what you want to do, you actually try it out, you study your results, and then make necessary tweaks, and then of course you go back there again. So we use this to test our changes and continuously improve the processes to give us positive results. I'll quickly give you a sense of the improvements we made. So in the HIV program supported through PEPFAR, we undertake a rigorous process of tracking patients through the pathway of care to ensure we can account for the clients and their contacts, you know, across the entire service cascade. But we were not doing this for TB. We were not doing this for TB services, at least not at the same intensity or extent as was done for HIV clients. So we sought to correct this by first helping the program teams understand better, you know, the TB cascade of care, which a good number of them struggled with initially. And also show them the importance of closely tracking patients through the TB patient pathway, and how not doing this was impacting our ability to give adequate care to the people living with HIV, and how it reflected poorly on the quality of our program. So over the years, if you look at this, you'll see these are tables of indicators, but over the years, the PEPFAR program focused mostly on key monitoring, evaluation, and reporting indicators, what we call the MARE indicators, which are the first 4 indicators you see on this table. We realized that not monitoring the processes of care, which are captured in the other indicators here in pink, not monitoring these processes of care that give you the results, which were essentially what those 4 indicators up there capture. Not monitoring the process of care was contributing to the problem. So we began to track and monitor the process indicators in pink. We also set targets for each step based on the expected yield for each service input. Remember, you can't hit a target you've not set. And I was recently reminded here at the Harvard Kennedy School, that setting a target lets you focus on doing well, not merely doing better than the minimum requirements. I think that was how they put it. So to enhance integration of TB HIV services, we also sought to incorporate the monitoring of the TB cascade of care. So we wanted to incorporate this TB cascade of care into an existing system, which is an existing system in the PEPFAR program, one of which is this incident command structure or system that was established by CDC Nigeria to accelerate HIV case finding and create a surge in the HIV cases. So they had the structure, and we just thought it made a lot of sense to layer on, not just layer on, integrate that TB cascade process into the existing HIV cascade process, which is essentially what they were doing. So that way, our TB HIV collaboration and TB HIV integration made a lot more sense. So this is a snapshot of the treatment cascade with the processes and the accompanying indicators that we started tracking and assessing on a weekly and monthly basis. This was not being done before. So we tracked patient flow from point of entry, which is the screening, until they were linked to treatment. We also did the same thing for TB prevention cascade, where we tracked patients, from the point of screening to initiation on TB preventive therapy if they were eligible for TB preventive treatment. So although we had metrics to measure performance and improvements, we recognized that a key critical success factor to the achievement of our objectives was our ability to engage all the relevant stakeholders, communicate with them, get them to understand the vision, be interested in what we were doing, get them involved, and then get them to support us. There is no way we could have adequately engaged stakeholders internally and externally if we did not deploy multiple communication channels like I had explained before. And if we did not manage our stakeholders appropriately. It was a key success factor for us, and it's something that we continue to advocate for. So what did we achieve with all the effort we put in? So you can see that we started recording some improvements in our TB screening among people living with HIV. We were not just screening more in terms of quantity, but the quality of the screening was better. So we could now begin to identify more people with symptoms of TB. We are mindful that the high percentage of TB screening doesn't necessarily translate into TB positivity yield. So that's why we make a lot of effort to monitor those process outcomes so that we can identify gaps and take the necessary corrective action. So as you can see here, because we were identifying more people with TB symptoms and testing many more than we used to, and we also strengthened the linkages to diagnostic facilities, we were now able to identify more patients with TB and then place them on treatment. And if they tested positive, that's if they tested positive for TB, but then if they had no symptoms or after the test, they were negative, then we considered them eligible for TB preventive treatment, of course, after ruling out any contraindications to the treatment. You recall I shared this slide earlier in the presentation. So this was the TB HIV pain point for all of PEPFAR at the end of 2020 when I joined. This is that presentation I did not like seeing. And Nigeria at that time was one of the PEPFAR countries with suboptimal TB screening. But by the end of 2022, Nigeria made progress. We had made some progress, and we joined the League of Countries with the highest TB screening rates. Now, this was despite an increasing number of people living with HIV that were enrolling on HIV treatment as well. And let me mention that this improvement you see here was not recorded by CDC alone. I say this all the time. One is not enough to achieve greatness. This is a joint effort of all the three PEPFAR agencies, that CDC, USAID, and DOD, that made this possible. And we're really proud of our shared vision. So you see that we formed a coalition, and together we were able to build the capacity of our respective partners and teams. Together we reviewed our processes and improvement plans, and we monitored the improvements and supported the improvement efforts together. So tomorrow is March 24, and tomorrow is World TB Day. So we will be marking this by creating awareness about the devastating impact of TB and then providing knowledge about ways to control the epidemic. But this year in CDC Nigeria, we've chosen to celebrate the TB champions in CDC Nigeria PEPFAR program. So I'm happy to say that from a one-woman riot squad, here we are, a full-fledged team, excited about continuously improving the quality of TB HIV care and service delivery and improving the lives of our patients. At CDC, let me say this, we celebrate small wins. We don't wait until the big win before we celebrate our people. In fact, we found that in the course of program implementation, that because of the effort it takes to create change, we need to regularly celebrate the efforts of our teams. We don't celebrate mediocrity, by the way, or false performance, but we celebrate effort, little successes, and major wins. So this is our team, and I thought I should showcase them to you so you understand that there's a whole lot behind the success we have achieved. And it all boils down to what we are talking about. So I'll summarize by saying that some of the lessons I have learned have been that principles, tools, and techniques of science of improvement are useful. They can enable small changes that can lead to big improvements. And it's important that as much as possible when you're implementing a program, you try to apply some of these tools because they really help. We also know, or we have found, that using a change management approach helps to prepare people for change. It also helps to hasten adoption of a process or a change that you want to try. And it places us on the right path to getting positive results, because if you follow those steps, maybe not step by step, but the principles, you're likely to get more people on board with your vision. We've also found that when we truly care about the people, the beneficiaries of the interventions, the health service providers, and even the implementers, they will become more excited, more vested about the positive impact of our well-researched interventions on their health, their well-being, and overall quality of life, really. We've also found that interventions are better implemented when the implementers care about the people to be helped and by the intervention. And when they care about the system, when they truly desire to build the system and improve the system. The same applies to research, by the way, that produces the evidence and says an intervention works or should be applied in a certain locality or region. You see, there's usually a difference when the goal is to improve lives or systems rather than rather than when the intention is to, just collect data, showcase performance, or publish and add to the body of knowledge. The saying that people don't care what you know until they know what you care is true. And it comes to mind all the time. And we see this quite often on the field. People are more drawn to your intervention, more drawn to what you're proposing when they see that you really care about them. And then finally, the leadership mindset. It is critical. Leadership, I keep saying, is responsibility. When we take responsibility, regardless of our position in the organization or the team, we're likely to make changes more. Also, developing leadership skills to drive change in a people-centered, empathetic, and structured manner will make it possible for the first 1, 2, 3 elements above to translate evidence into action or change. So I believe it's important, I really believe, and I say this all the time, that we need to build leadership capacity very early in life. I tend to advocate that this capacity should be built from when people are really young, when they're in school, then through to the early career stage, middle level, and then senior level. Because the ability to deploy good leadership knowledge and skills is critical to moving us from evidence into action. Good leadership skills and knowledge will also enable research to be conducted properly and ethically, such that it gives you accurate results, which can be applied with great benefit for the end users. And so I tend to also say that when we are looking at leadership when we're looking at the impact of leadership on our research or leadership on our at any level, really, that we should also look at it with great care. So sometimes the choice to make a change or not is really ours, regardless of the obstacles we face. I just want to say that the changes we have recorded in the TB HIV program in PEPFAR Nigeria, they're not big changes. They are small, but they are also positive changes. But we are confident that these small changes can lead to big changes over time, and we're going to keep at it. Let me just say thank you for the opportunity to share a journey with you.
Thank you so much, Flora, for that inspiring talk. I have a piece of paper next to me, and I've written about 20 quotes from you, including leadership is responsibility, and then it's an art that can be used to take research into action. This was very inspiring, and we can all learn so much from you. Does anyone have any questions or comments?
Sure, I have a question.
Jesse, go
That's
ahead.
okay. Yeah, thank you. Thank you, Flora. I have a question for you from the perspective of our school. So the work you're doing is very much aligned with the kind of things that we expect our graduates to do and the kind of research that our faculty does. And I have this feeling that we could connect better with it. So what kind of coursework do you think we should have to prepare our students to learn the way that you have and to do some of these things with the advantage of formal preparation?
So for one, I will start with, I've engaged with a number of the students in, well, a few of them in Harvard, and I see that they're very strong, or they're likely to be very strong in the area of research, right? Because they're surrounded by, state-of-the-art researchers. But I think we need more practical exposure. And this is not even just, it's not something we see just in Harvard. So I remember a time when I was working with Shell Nigeria, and there they would have a good number of some of the researchers come from the universities to spend 1 year sabbatical with them. And you could tell that what the experience of, full-fledged researchers in a field different from the academic environment was different. I remember somebody said to me, Flora, he has come to understand that if you do not merge the theory with the practical aspect, we're not going to get very far. So one of the things I think I would advise is very early we get our students involved in this on the field work, apply themselves, go out. We do that in CDC. We have interns, we have people who come in, and it's usually a wow experience for them. They begin to see that things are really different. The field is different. They also begin to see some of the challenges with implementation. They also begin to think differently, even when they are designing their research, with a view to, applying it in a particular location. So I think if we start early to expose them to, practical realities, going to these places, it will help. Two, I think it would be good if we, in part of our curriculum, the way we teach leadership, you teach leadership in Harvard, you're exposing people to a new way of thinking. I think it needs to start early, back here as undergraduates. We didn't have that. Honestly, I think when I was in medical school, the only thing I knew was the science, all the pathologies, all the physiology, how the body works. Nobody taught me anything about leadership. Much of what I learned about leadership was either from reading books or, from shadowing one or two mentors. One of my mentors is here. In fact, I think much of what I learned about leadership, I think I learned from him. He was a senior person, he was in management, he was in public health, but because he was in a corporate setting, his thinking was different, I think that learning at that early age in the curriculum, and it's something we're also looking to see how we can do here in Nigeria, how we can expose people to a different mindset, a mindset that does not limit them, is not narrow, but is open to understanding how we can actually catalyze change. So I think if we can start to include our leadership trainings in this at the undergraduate level, it will help, and then expose people to, other settings and the field where this work actually gets done. Believe me, it will change the orientation.
Thank you. Jesse, do you have a follow-up question or should we move on to Nick?
Well, a comment, which is when you need interns or you want people to expose, I'm sure we'd have many candidates for you.
Nick, please.
Okay.
Say that again, Prof.
Jesse was suggesting that we have many candidates here who would like to learn from you and developing their leadership skills. And I agree.
Oh, really? Yeah, interesting. I'm still learning, by the way.
Yeah, I guess so. I'm going to double up. I have a comment and a question. Just to echo Jessica, this was fantastic. And so I think I spent most of the day talking about TB, but during this presentation, I was the most enthusiastic about what we're trying to do. And I think you communicated it really well. So thank you. Question. So, and I used to be based at the CDC in Atlanta, working on what was at the time the Global AIDS Program. And from that perspective, I felt that occasionally the US government was rather fickle in terms of how it worked with countries, that, what the US would fund some years was different from what it would fund other years. The priorities changed and weren't always the country's priorities. But, that was a view generated from Atlanta. I was wondering how this felt from your perspective. Like, was there a challenge in dealing with shifting priorities? And if so, how did you deal with that?
Right. So let me start first of all from my experience. So I mean, when I got into the organization, so imagine coming into the the PEPFAR program and colleagues say to you, Flora, nobody cares about TB here, and I mean literally, right? And I'm like, no, how is that possible? I belong to the division of global HIV and TB. And you tell me that nobody cares about TB. How in the world can you say that? Not to mention the people you're trying to keep alive, TB is gonna kill them. It was like an oxymoron to me. It didn't make sense. But I thought it was a Nigerian thing until, as I started engaging with the countries and then with our HQ, just realized that this was a global PEPFAR problem, right? So I sat back and thought, what do I do? But you see, I couldn't work alone. So I started, first of all, in country. I became a nuisance. In fact, so much of a nuisance that they gave me two names. One was TB activist, and then the other one was the TB demolition queen. Because every moment I started advocating, I kept saying to them, it just does not make sense. TB is killing these PLHIVs and we're doing nothing about it. So I used my voice. I was in everybody's face. I would go into meetings with PEPFAR in our HQ, and when they want, and then I would make a case. So in fact, people knew me, they knew this Nigerian woman because we were making that case. We were putting it out there, so much so that I was so happy when I saw recently in a retreat I joined where it was like people were waking up to the realization. And I think sometimes the struggle really is not that they don't want to do it. Just like you have said, the priorities may be different, but you see, people will always prioritize other things if you keep quiet. You have to make a case for what is important. That's what I have found. When you keep quiet, nothing happens. So you must make a case. Sometimes it may come with consequences, but then we need to try. And we also have to build coalition. We need to get people to support us in this journey. We can never do it alone. So we need to work with others. And I think we've come to that point now where we are able to, get more people on board with this fight. And then now you find a whole lot more people interested. And then another thing I have found that works is you need to communicate what you're doing. Many times people don't see these things. Until we started sharing the work we were doing in the area of TB, then getting the stakeholders involved and also, bringing in their, making a case, the stakeholders would also come in and say they don't understand why we are not prioritizing TB. So there were so many people we need to bring on board. And then, by the way, let me mention that now, because of the new direction that PEPFAR is taking, which is the global health equity, they're now getting more feedback from the countries. So now they're trying to work with countries collaboratively to decide on priorities. This has not always been the case. It's a new direction. It's very welcome, and I think this is an opportunity for us. And we say this all the time in our country office. This is an opportunity for us now to ensure that the things that matter to us as a country, as a people, are put to the fore. So that with this new direction that we're taking, they can get funded if possible. So things are changing, but it will take a while to really get to that point where some priorities become more important than others.
Thank you. Anyone else? Then I'll jump into the question. Laura, one thing that I've asked you in our own conversations, and I wondered if you could chat about here, because it's something that I think a lot about in my own work, is how can researchers design research and communicate results with an eye toward being useful for implementation and policy? You've talked a lot about how your role is to catalyze sort of the translation of research into action. Are there things that we can do at the research stage to improve the chances that the results are valuable and translational?
Yes. So, in CDC, we do quite a lot of operational research. And when we do it, we do it in conjunction with our colleagues in HQ. In fact, many times you find that because a lot of the research, well, okay, maybe not a lot now, it's almost 50-50, but they also initiate research from Atlanta. But then we usually review all our research findings together. And we find that when they begin to interpret, they're very scientific in their thinking, which is good and is necessary. But when you interpret data without context, you're likely to infer wrongly. So we try to help them, first of all, understand the processes that got those results, and then two, understand the scenarios around the results that came forth, right? So we're able to situate the results within the right context so that it makes sense. Because you see, if not, if you look at sometimes when you look at the findings the way they are, you would come to the wrong conclusion. And that's what we try to do. We try to help them look at it based on the prevailing circumstance. So let me say, for instance, in Nigeria, our TB screening is essentially done through symptom screening, right? And we also have a system, we also have this challenge of moving samples and not patients, right? So samples are moved, and in the process, you can have some leakages. So many times when you look at the data, you probably look at the data and then there are quite a number of leakages. You don't understand how those leakages came about. And so you would look at the data and just say, oh no, this is not significant. But the denominator has not really been looked at because of some of the leakages. So we tend to highlight those things so that people can understand that, look, the denominator, what we're engaging with is not correct. And the reasons they're not correct is because of this, and this. Or some of the source documents from which they get their data. In Nigeria, that's a problem we have. Our source documents are usually a problem, right? And so by the time the data comes out, sometimes it's not. And really the problem is that the data is incomplete. So when you don't know that, or you don't have that information, you would assume that this is all you get. So it's always important to ensure that you're working with the right people when you are looking at result findings, and also to ask questions about why things are not the way they are before you make an inference. It's one of the things we found. There was something else I wanted to mention, that another thing we need to think about too when we're trying to design research is to also to ask if that research is going to really benefit the people. So recently, somebody came up with wanting to do a cost-benefit analysis or a cost-effectiveness analysis on contact investigation, on what the cost effectiveness analysis of contact investigation is. And when they brought it up, I said, and then whether it's been proven to be effective. I said, look, there are lots of studies that show that contact investigation for TB is not exactly, is costly, it costs a lot, but it is effective. Right now, our need is not to do another cost effectiveness analysis. Our need is really to actually do contact investigation, which we have not started doing in the PEPFAR program. So we're able to redirect them to something that would be beneficial to the people and to the program, rather than, just be a, maybe data extraction or, add to the body of knowledge, which already is full with that evidence anyway. So these are also some of the things that we try to do. Over.
Thank you. Does anyone else have a question or a comment? Any last thoughts? Okay, great. Then I'll say thank you so much, Flora, for this inspiring talk. I think we all learned even more about leadership and inspirational work than we did about TB, although we learned certainly a lot about TB and people living with HIV who have TB. So thank you so much. Just to plug everyone that Flora is around, as are the other lead fellows. And so please, if you would like to engage with the lead fellowship program that we run, please send me an email and I'll try to arrange it. So thank you so much.
Thank you.